Okay, so this is our congenital peds talk, congenital neuro peds talk, that is, um, focusing on primarily brain malformations. So, starting out with a this versus that case, I just want to talk about briefly the differences between a what a pediatric brain MR can look like versus an adult brain MR. So remember that you aren't born with a normally myelinated brain. So, and myelin is basically fat. So that's going to change the way that things look. Now, when you're trying to figure out what a study is, normally, and I'll repeat this throughout the neuro talks, first thing you do is you look if you can see some CSF. Bright CSF is going to be T2. Dark CSF is either going to be either T1 or flare. Now, the way that you tell the difference is that white matter should be white on T1, white matter should be dark on T2. But that's in an adult. And a kid, it's different. And it depends on the age of the child. So a T1 image is not going to look like an adult image until the patient is 1 year old. And a T2 image is not going to look like an adult image until the kid is 2 years old. So 1 for 1 year, 2 for 2 years. So this is actually a T1, and this is a T2. It's the opposite of what you'd expect, where white matter is actually dark on T1 and white matter is actually white on T2. So the pattern of myelination is from back to front and from bottom to top. So depending on sort of 6 months, 9 months, etc., it would be a very, very difficult question that would be far beyond the scope of this test, I would think, to tell you to date the patient's age based on the myelination pattern. But that is something that people can do, and it's because of this back to front, top to or bottom to top pattern. Now, the brainstem and posterior limb of the internal capsule are normally myelinated at birth, and that is a piece of trivia that could be asked, although that would be pretty tough too. So congenital peds brain stuff can be thought about basically in a couple of different flavors. You can think about stuff that has a failure to form, a failure to cleave, or a failure to migrate. And that's how we're going to go through the bulk of this talk. So let's talk about failure to form first. So this is an Aunt Minnie case. I think I've got a case like this in the case companion book. And it's two ways to show the same thing. First one is these vertical appearing, widely spaced ventricles, like race car tires. Another one is this, colpocephaly. That's when the back part of the lateral ventricles looks big like this. And then the last one is the so-called steer horn deformity, which looks like that, and that's shown on the coronal. This would be an ultrasound steer horn here, and then ultrasound colpocephaly there. So what is all this trying to show? It's trying to show this. Absence of the corpus callosum. In this case, it's sort of hypoplastic. The back part is missing. So there's a normal-looking corpus callosum. So how does the corpus callosum form embryologically? This is worth knowing. The corpus callosum forms from front to back, and then the rostrum is last. So if we go back to this case here, you can see that it was forming front to back, stopped right there. You have no back, and you have no rostrum. All right. So pretty much covered that. Yeah, front to back, rostrum last, partial agenesis, could just have the front part. Vertical ventricles is the description for this, and the steer horn deformity. Now, you'll see a buzzword a lot of times it shows up in books and those kinds of things with regard to absence of the corpus callosum, referring to these so-called Probst bundles. And like, what is that? Basically, these are white matter bundles that are destined to cross the corpus callosum. They run parallel to the interhemispheric fissure, when there is no corpus callosum to cross, and that creates this wide space lateral ventricles. So this is what they're supposed to do. And then if you don't have a corpus callosum, they do something like that, which creates the widely spaced appearance of the lateral ventricles. So what are some associations of agenesis to the corpus callosum? The one that's probably worth knowing is the pericallosal lipoma. This isn't a real lipoma, it's technically a hamartoma, but as I'll mention in the neuro talk on temporal bone, these things are usually midline. They can occur in the IAC. They're typically midline lipomas, that is. You can see them in a suprasellar cistern or pericallosal. This is a good example of a midline one. When you see a midline pericallosal lipoma, you should think about agenesis of the corpus callosum. So next failure to form case. This is a coronal brain MR. It's kind of funny looking. Look at that cerebellum. Notice anything weird? So this is the transversely oriented single-lobed cerebellum that you see in rhomboencephalosynapsis. When the vermis doesn't develop normally, you end up with fusion of the cerebellum, and that's what creates this appearance. It's an Ant Mini. Next case, failure to form. This is another Ant Mini, very classic. This is a so-called molar tooth sign here and here. And what that is an absence of the pyramidal ductusation. It results in a small or aplastic cerebellar vermis. Strong associations worth knowing: retinal dysplasia 50% of the time, and multicystic dysplastic kidneys 30% of the time. All right, another failure to form. Another Ant Mini. This is a big CSF collection back here, and this is so-called Dandy Walker malformation. What you end up having is variable degrees of vermian and cerebellar hypoplasia. The most common presentation of a Dandy Walker is actually increased intracranial pressure from hydrocephalus. So you end up with this enlarged posterior fossa, and that creates this torcula lambdoid inversion. So what the hell is that? I mentioned this in one of my other talks. This thing here is the torcula. That's the so-called confluence of sinuses. The lambdoid is a suture that's on the back of the skull. And when their relationship, which is normally like this, becomes inverted like that, that is torcula lambdoid inversion. And it occurs secondary to a high tentorium and is a classic buzzword for Dandy Walker malformation. So there's a whole bunch of Dandy Walker things and a spectrum of stuff. Neuroradiologists love to obsess over this. Basic take-home points is that a true Dandy Walker malformation, you've got vermian and cerebellar hypoplasia and this enlarged posterior fossa. With a Dandy Walker variant, the posterior fossa is pretty much normal, with your vermian hypoplasia being much less severe. Now there's another entity called a persistent Blakemore pouch, where the vermis is actually normal, and instead you have a cyst that's below the vermis. Notice that there's a cyst that's sitting below the vermis. Again, posterior fossa is normal. And then you have a megacisterna magna, which has a pretty much normal everything, except the posterior fossa is enlarged. So posterior fossa enlarged here, posterior fossa enlarged here. So that and that. Okay, megacisterna magna and Dandy Walker, ironically. The one that really doesn't have anything wrong and the one that has the most severe things have the enlarged posterior fossa. The Blake pouch looks like a cyst, and the Dandy Walker variant is just a less severe version of Dandy Walker. Okay, now let's talk about failure to cleave. So these are three things. They're in the same spectrum of diseases, and they are all a failure to cleave. It's a midline cleaving problem, and this is holoprosencephaly. So there's a spectrum that goes from lobar to semi-lobar to alobar with variable degrees of cleavage voiding, or lack thereof cleavage, failure to cleave. So in the alobar type, this is the most severe. You've got a giant, large ventricle. This kid can have other midline defects, may look like a cyclops. Semi-lobar is the medium one. The thing to know about this is fusion at the thalamus, most commonly anterior. So where corpus callosal forming is anterior from front to back, cleavage occurs from back to front in this direction. So you may still, you can have a lack of cleavage occur just in this anterior part. You cleave normally here. And then the lobar type is the most mild, and you may only have partial absence of the frontal interhemispheric fissure, or it didn't cleave all the way through, or you can have a little bit of corpus callosal issues or pituitary problems, which of course is also a midline defect. There is this association with renal cysts and holoprosencephaly called Meckel-Gruber syndrome. This kid also tends to have too many fingers. Polydactyly, they call it. Next case. This is another midline defect. Notice that anything's missing here. So the septum pellucidum is absent. And anytime you're shown this image right here, where the optic nerves are, you can think about demyelinating issues that are affecting the optic nerves, if one's brighter than the other one, or in this case, if they appear smaller than you would expect, especially in the setting of this finding, then you think about septo-optic dysplasia, which is the mildest form of holoprosencephaly. And again, midline issues, holoprosencephaly has problems with another midline structure, the pituitary. So now let's do failure to migrate. This is our third type. So we've got an axial and a coronal brain MR, and what you're noticing is that this part of the brain appears big over here, like fat, and like this guy's been lifting weights, this guy's been sitting on the couch. But this ventricle is big, so big brain, big ventricle, as opposed to the ventricle being smaller and bigger on the other side. So this is hemimegancephaly. It's an enlargement of all or parts of one cerebellar hemisphere. And you'll notice that, like I pointed out, big side has a big ventricle, as opposed to the small side having the big ventricle, which is more of an atrophy thing. And that's what Rasmussen encephalitis looks like, which would make a good distractor. So everything's big in hemimegancephaly. Okay, so next failure to migrate case. This is, let's take a zoom in here. We've got a good view of the pituitary, and instead of having the normal bright posterior pituitary bright spot here, we don't see it as we're looking around, and notice it's there. It doesn't belong there. So this is a common cause of pituitary dwarfism, although you can see it randomly. All right, next case, another this versus that. So this is a classic this versus that. This is in my case book. And what we've got here is a porencephalic cyst versus a schizencephalic cleft. Now, how can I tell the difference? If you squint, you'll notice that there is gray matter lining this cleft, meaning that it's a true malformation. The gray matter is not lining this. There's white matter lining it. This is basically just a hole from prior encephalomalacia or ischemia. In other words, you had a normal brain there, then you had an infarct in utero, and it took it down. So look for the gray matter lining the cleft to be able to call it schizencephaly. All right, so this is a good case for problem solving. All right, now I'll tell you that this is one that we've seen earlier today. This is alobar holoprosencephaly, and this is something new we haven't talked about called hydranencephaly. Now, how can I tell those apart? Just looks like a bunch of CSF to me. So here's the algorithm that I'm suggesting you use. The first thing you want to look for is a cortical mantle. A cortical mantle is the brain on the outside, sort of lining it like a brain skin on the outside. It's either present or it's absent. If it's absent, it's hydranencephaly. And the way to remember that is hydranencephaly is basically a bilateral MCA infarct. So this is total encephalomalacia that goes all the way out to the end. And that's not going to spare the outside, right? Strokes don't do that. Now, we have a cortical mantle. We're not finished yet. You have to look for the falx. So if you have one present, which is here, then you're just dealing with massive hydrocephalus. If it's absent, remember the falx is a midline structure, holoprosencephaly is a midline problem, then that is what's going to lead you in the direction of holoprosencephaly. So as I mentioned earlier, hydranencephaly is just a large bilateral MCA infarct, and that's why it goes all the way out to the end. You didn't have any kind of midline cleavage problems, so you should still have your falx. Okay, another sort of miscellaneous topic. This is a T1 weighted MR, and I will tell you that this is a kid who is a low birth weight kid, and I'm sort of pointing out this anatomy of this caudothalamic groove. So probably more used to seeing hemorrhage at the site of the caudothalamic groove in these head ultrasounds that more than likely you've been forced to read 1,000 of during your residency. But just to remind you that this is the site of germinal matrix, and it is the most common site of germinal matrix hemorrhage in a prenatal kid. So this would be normal versus a grade 1 there, bright stuff. The choroid is not supposed to, the choroid here, there's bright stuff, it's not supposed to extend into and past that caudothalamic groove, and when it does, then you have to call it grade 1, which is a pretty good correlate right here on MR. So premature infants, major take-home point here is that the germinal matrix is no longer present after about 34 weeks. Don't go calling germinal matrix hemorrhage in full-term infants. That's how you look stupid. You don't have a germinal matrix, so you don't have a germinal matrix hemorrhage. Typically, they image them within 1 week after birth, as most hemorrhages occur in the first week, usually within the first couple of days. So there's a grading system. You can have grade 1, which will either resolve or progress. And sometimes you can end up with a subependymal cyst, sort of looks like that, as a sequel of old hemorrhage. You can have further progression into grade 4, which can result in badness like hydrocephalus or a porencephalic cyst if you end up having some dead brain. All right, so next case, this I will tell you is an ultrasound of the neck in a kid, palpable mass. Do you want to biopsy that? Remember what I said, anytime somebody asks if you want to biopsy, the answer is, hey, is that a vessel? I'll tell you it's not a vessel, but it is something you should be able to recognize, and the trick is actually this here. Notice that there's two of them. Looks like one here, but when you turn on it, looks like two. That's because there are two heads of the sternocleidomastoid. So this is fibromatosis coli. It's just a benign mass of the sternocleidomastoid in neonates. Classically shown as 2 and 1 like that. It'll go away with physical therapy, doesn't require surgery or anything crazy like that. Another neck case, this versus that. So we've got two different cysts one here in the midline and one here laterally. So the midline cyst in a kid is the thyroglossal duct cyst. The lateral cyst in the neck of a kid is the branchial cleft cyst. So remember, thyroglossal duct cysts can occur anywhere from the foramen cecum, which is the back of the tongue, all the way down to the thyroid, and they're midline. That's the key. Branchial cleft cysts are lateral. There's a whole bunch of different types, but like 95% of them are type 2, so if you're forced to guess, I would pick type 2, assuming that it would be difficult for your test writer to find you a case of something that's not type 2. Be aware, especially in an older person, that a necrotic level 2 lymph node can mimic a brachial cleft cyst. If you're thinking, hey, that patient's too young to have floor of the mouth cancer, watch out. HPV can cause floor of the mouth cancers in fairly young people. All right, next case here. This is a gradient sequence, and I'm showing you blooming in the back of both eyes. Blooming meaning there's calcium. I could have showed you this case as calcification bilaterally also. So in a kid, unless there's some kind of weird trauma, this is a retinoblastoma until proven otherwise. Remember, this can be bilateral or trilateral. You can have involvement of the pineal gland, which is your third eye. So that's your DMT spirit molecule is going to be coming out of your pineal gland, and that's what you're going to use to see there. So unilateral ones are more likely to be sporadic. Bilateral ones and trilateral ones are more likely to be associated with bad juju, RB suppressor gene, chromosome 13. Remember that that's the same one that is on the that osteosarcoma gene. So if these kids get radiation to their face, they often end up with osteosarcomas in their face as opposed to long bone. Okay, so that's the end of this talk, and the next series is a dedicated neuro series.